I'm a circus acrobat. And I'm a weight-bearing circus acrobat, and I've been leaning too much, and my radial aspect started to hurt, and I got a dorsal impingement, and I got a ganglion, and I started to get stiff, and so I changed my technique, and instead of having my hands forwards, I shift my hands out to the side like that. What's going to happen next? I'm going to start getting exactly what you're poking, which is that I'm going to start putting load on the ulnar aspect of my wrist, and instead of getting a tension-based swing tennis TFCC injury, I'm going to get a compression-based TFCC injury because I'm sitting through my ulnar side, because now I'm weight bearing through my ulnar side. And it'll work in exactly the same way as what we were talking about on the radial aspect. So I'll have a potential tensioning of the underside of the ulnar carpals, and will my FCU work too hard? Almost certainly. But that's a much more powerful system on the ulnar side, where I've got pisiform working really strongly in that area. So I'm less likely to get an extrinsic ligament concern, but what I will get is a compression-based injury to the TFCC disc itself, and I'll get what they'll call it an undersurface. You know when you get a meniscus in a knee and they've had a compression injury to it, and they'll get this undersurface tear to the way that, and you know that their meniscus is annoyed, and they have this grumbly meniscus, and they can lean on it and rotate, and they know that it feels uncomfortable. You'll have had those. And on the MR, it's kind of equivocal, and there's not this big flap tear, and it doesn't look horrible, but you know that they really don't like weight bearing and compression and rotation. That's exactly what they present like in an ulnar-sided wrist. And so then you go, okay, now I'm just going to do exactly the same process that I was doing before of where I'm going, let's pretend we now get the diagnostics right. We know that we've got a TFCC tear. We know that it's not a great big flap tear and that's going to get operated on. And blessings to the orthopedic surgeons, who I totally love, who are really good at this. The solutions for TFCC disc operations are smaller and harder than they are for a meniscus. And we're not brilliant at doing them in a meniscus. And I think probably with the meniscus too, we as physios have to put our hands up and go, we don't shut people down aggressively enough when they have a meniscus injury in terms of what we let them do weight-bearing wise. We let them still move too much, and they get sore, and then they don't get better, and then they go and have an operation to get it cleaned out. And I think we could probably be more aggressive about managing how they're weight-bearing. And I say that in a talk about wrists because it's exactly the same conversation with a TFCC in your wrist. Is you get a TFCC compression injury, it's probably going to take 12 weeks to heal. It's probably going to take 12 weeks, depending on how long it's been around for and what it looks like. You might be able to settle it down so they can be symptom-free in somewhere between 1 and 4 weeks. So it means your immobilization time or your shutdown time might be as short as 1 to 3 weeks. You put them in a splint, you send them off to our groovy splint people, and they'll essentially make a splint which stops them from being able to wrist extend, stops them from being able to weight bear, and stops them from being able to supinate. Does that make sense? And they're super useful from that perspective. But what we then want to do is go, okay, let's get them out and let's make sure we've got the movement that we want to be able to do. But we want to get better at, okay, how much compression can this ulnar-sided wrist take? So you'll notice I could go back to using the other one, but this one's plugged in and Brad was nice to me. So you can see on the screen if we wanted to, I can just start putting weight where I'm putting it through my ulnar-sided wrist now, and I'm going, okay, that's 5 or 6 kilograms worth of load. And then I go, can I do that into extension if I just move like that? Can I put that, oh, sorry, mate. That should take me far enough, is can I do that in some form of extended version of that story, where I'm then loading and adding rotation to the story to see what that feels like, and I can then quantify the numbers of that's my subclinical threshold, and you can give people an appropriate home program of knowing what they want to do. Whereas we said before, we don't want them to do nothing, we just want them to do somewhere between 50% and 99% of their therapeutic load. And if they're doing 105% of their therapeutic load, they'll probably get worse. And if they're doing 98%, but you don't know exactly what it looks like. So, but they're also going to get lots of value out of doing that 50% range. So doing lots and lots and lots of easy weight bearing on the ulnar aspect of the wrist in a non-symptomatic way. And remember those exercises we did last time, you're going, okay, I also want to learn to push my wrist flexors through my 5th MCP, not through my pinky. We're not talking a flexor digitorum, you know, we're not talking a distal program, we're talking a proximal program. We want control that's happening in and around the wrist itself, so that you can start to regain that control, and then you build it back up and you put that into whatever it is that you need to do.